Sorry, I'm waiting. Okay. Lassa fever is one of the viral hemorrhagic fevers caused by Lassa fever virus, which is an enveloped, single-stranded, bisegmented RNA virus of the RNA viridae family. So by the side there is the picture of the virus and then the rodents that transmit this virus, which is a multi-mammate rat, Mastomys natalensis, discovered in Nigeria in Lassa when some nurses were affected. It is endemic in portions of West Africa, Nigeria, Sierra Leone, Guinea, and up to the Central Republic. Is estimated 100,000 to 300,000 infections occur per year. It's 5,000 deaths occur annually. As at for the 2023 in Nigeria, for the 2023 outbreak, there were about 4,702 suspected cases, 5 probable cases, and 877 confirmed cases, and 157 deaths among the confirmed cases, with a case fatality rate of 17%. For this year, between January and February, we have had about 3,215 suspected cases and 573 confirmed cases, and 108 deaths, making cumulatively, and the case fatality rate is about 18.8%. This is from the NCDC for January to February. So it's a yearly outbreak, usually during the dry period between December and April. It affects all ages, both sexes, even pregnant women. In fact, it's more for pregnant women. It's a poor prognostic disease. It's also a zoonotic illness. So there are case definition for this condition. For the alert case, any person who has an unexplained fever, malaria, or other common causes of fever has been ruled out with or without bleeding. So you alert yourself or any person who died after an unexplained severe illness with fever and bleeding. Suspected cases are defined as patient with fever for 3 to 21 days with a measured temperature of 38 degrees or more, with one or more of the following: vomiting, diarrhea, sore throat, myalgia, or in illness, maternal Lassa fever plus or minus signs and symptoms. For the probable case, a suspected case who has one or more of the following complications: hearing loss, facial or neck swelling, seizures, restlessness, confusion, hypotension, oliguria, and any of the following supporting laboratory features: proteinuria and or microscopic hematuria, elevated urea of greater than 45 milligrams per DL, elevated transaminases, reduced platelet counts. Confirmed cases, a suspected or probable case with a positive laboratory test using real-time polymerase chain reaction. In treatment centers where it is practicable, all cases, suspected, probable, and confirmed cases, further separated into wet and dry. So the wet are those that come with bleeding, vomiting, diarrhea, coughing, sneezing. For dry patients, don't come with the above symptoms. Any of the following scenarios should raise the index of suspicion because it's a very condition. So high level of suspicion, high index of suspicion is required for us to make prompt diagnosis and management. Patient has not responded to standard anti-malaria treatment and treatment for other common infectious causes of fever within 48 to 72 hours. So that's the default that happens when people develop symptoms of Lassa fever, headaches, joint pains. The default is to go and treat for malaria or other infectious diseases. So history of recent contact with probable or confirmed cases of Lassa fever within 21 days of onset of fever, patient with history of fever and history of travel to high risk or high risk area of Lassa fever, contact with body fluids or tissues of a dead patient with a febrile illness. So the transmission, we say Mastomys is responsible. So for rodents to human, so inhalation of aerosolized virus, contact with urine and feces of the rodent, catching and preparing Mastomys as food, ingestion of food or material contaminated by the excreta of the of the rodents. Human to human also there can be transmitted. Inhalation of aerosolized virus, direct contact with blood, tissues, secretions or excretions of infected humans, needle stick injuries, vertical transmission, sexual transmission has also been reported. So Lassa fever virus undergoes cellular entry via endocytosis, alpha-dystroglycan cell surface receptor on the endothelial and dendritic cells. Once in the cells, it enters the endosomes, evade endosomal degradation using envelope proteins which mediate a pH-dependent binding and membrane fusion. Then it continues, and there's intracellular RNA synthesis initiated with an L polymerase enzyme, which utilizes viral RNA templates and nucleocapsid protein to synthesize viral ribonucleoprotein. So the end result is vascular dilatation, increased vascular permeability. All these are mediated by inflammatory cytokines. And then prompt host immune response is critical for host survival. But however, this virus tends to modify the innate and the adaptive immunity, thereby causing the damages it causes in the human. So this is just a pictorial diagram. So the incubation period usually varies 5 to 21 days. Some say 22 to 21 days or 3 to 21 days. Maybe asymptomatic. Actually, majority are asymptomatic. And when they come down with symptoms, they have fever, headache, malaria, laryngitis, myalgias, retrosternal pain, cough, vomiting, diarrhea, abdominal pain. They could also come down with abnormal bleeding from mucosal membranes and puncture sites, neck or facial swelling, shock, conjunctivitis, sore throat, confusion. Rarely they come down with maculopapular rash. And as I said earlier, it's severe in pregnant women and newborns. So the diagnostic investigations include the ELISA to detect antigens for IgM and IgG, usually for resource poor setting, and is usually used for seroprevalence. What we use commonly is the Lassa virus reverse transcriptase polymerase chain. It can detect this virus within 7 to 10 days. And then we can do a virus isolation, immunohistochemistry, usually for postmortem. Supportive investigations are full blood counts, E and U creatinine, liver function tests, urinalysis, throat swab, MCS clotting profile, ECG, chest X-ray, EEG, MRI, arterial blood gases based on, depending on what they present with. So the treatments, there are two regimens that I use, McCormick regimen and the Irua regimen. So for the McCormick regimen, for non-pregnant women, loading dose is about 33 milligrams per kg with a maximum dose of 2.64 grams start. And then you give half of that dose day 1 to 4, 6 hourly, and then half of that for that half for day 5 to 10. Usually the treatment is for 10 days, both for the McCormick regimen and for the Irua regimen. So for patient who requires dialysis, you give this revive within 4 hours before dialysis. For the Irua regimen, it has a loading dose of 100 milligrams per kg to a maximum of 7 grams, where you give to third, start, and then on third, giving 8 hours. 8 hours after 8 hours. Then for day 2 to 7, you give 25 milligrams per kg. Day 8 to 10, then 12.5 milligrams per kg. For pregnant women, for the McCormick, you give a loading dose 100 milligrams per kg, and then day 2 to 5, 60 milligrams per kg. Day 6 to 10, 8 milligrams per kg. Okay. And they said each of these doses must be given a slow intravenous push over 5 to 10 minutes. So the supportive treatment, usually these patients are treated in an isolation ward, and this isolation ward usually will get all the necessary equipment, even for ICU care. So they will have ventilatory support for those that might need ventilation. So you usually admit these people into an isolation ward, you check for the E and U creatinine, and treat for any electrolyte imbalances, pain relief. You want to give pain relief for this patient, blood transfusion if need be, antibiotics support, vasopressor support, renal replacement support, because the isolation ward too could have a dialysis unit, also supplemental oxygen if need be, nutritional support, anti-seizure for those that come with seizures, and PPIs for those that come down with dyspepsia. So precautions to be taken: NSAIDs are usually contraindicated due to risk of bleeding, avoid intramuscular injection as much as possible to avoid hematoma formation, use cotton wool to clean the mouth of patient instead of hard toothbrush. All this is just not to provoke bleeding. Any skin ulcers must be cleaned and dressed gently. Avoid nasogastric tube, urinary catheter insertion unless strongly indicated. Do not remove old blood clots from previous bleeding sites because it could cause rebleeding. Never recap needles. For pregnant patients, gentle vaginal examination if necessary. Do not enter patient's room or get in contact with patients without fully gowning with your PPE. So differentials malaria, as I said, the symptoms are so similar. So most times when people come down with this illness, they tend to go and treat for malaria, typhoid, could be sepsis, could be other hemorrhagic fevers. Complications: acute kidney injury, increased serum creatinine of 0.3 milligrams per DL within 48 hours, or reduce urine output or no urine for at least 6 hours. They could also have severe central nervous system features like seizures, so we can do an EEG for them, restlessness, confusion, and coma. We can do a brain imaging for them if they are unconscious, severe bleeding, respiratory distress, severe anemia requiring blood transfusion, sepsis or hypovolemic shock, sensorineural deafness, pleural effusion, pericardial effusion, and can lead to death. So the poor prognostic signs are abnormal bleeding, encephalopathy, shock, later commencement of reviving after 6 days of onset of illness. It's said to be poor, to be a poor prognostic sign. Age less than 5 years or greater than 50 years. Those that come down with AKI or elevated liver enzymes, seizures, altered consciousness, hyperemia, or third trimester of pregnancy. So all these are poor prognostic factors. Discharge. So you do a PCR testing carried out at day 10. If it's negative and patient is if febrile, you discharge. Or in centers without facility for PCR, discharge patient in the absence of signs and symptoms after 10 days of treatment, or for symptomatic patients with negative PCR, discharge into appropriate ward for subsequent management. So if the PCR is negative and patient is still symptomatic, you can transfer to a normal ward. So PCR is positive after treatment, but there are no symptoms. Also, you can discharge. Suggestive, of course, there are no symptoms suggestive of Lassa fever for 72 hours post-treatment. Patient should, however, be followed up, and oral ribavirin must be given at 500 milligrams 6 hourly for 7 days. So if patient is still PCR positive at day 10 and still symptomatic, treatment can be extended for 5 to 10 days. Recommendation for follow-up: patients should be followed up weekly for the first 3 weeks and monthly for the next 3 months. After discharge, patients should be evaluated consistently for hearing loss and other complications. Nursing mothers should not commence breastfeeding until breast milk test is negative. Supportive nutrition is encouraged for babies whose mother's breast milk test positive. Semen should be tested after 3 months, and patient advised to avoid unprotected sexual intercourse during this period. If semen remains positive, patients should be counseled on the use of protection. Prevention. This is key. Health education is very important. Proper food storage, avoid spreading food on the highway, proper burial practices for deceased patients, proper use of PPEs. So health education generally on how to prevent. So the advisories on how to prevent this condition. So primary prevention, post-exposure prophylaxis for those who come in contact with patients that have Lassa fever. Secondary prophylaxis, prompt diagnosis and treatment. This is where high index of suspicion is very important, and treatment commence as quickly as possible, because we saw earlier that commencement of ribavirin is a poor prognostic factor. Tertiary prevention, so treat and identify complication and rehabilitate the patient. So in conclusion, Lassa fever is endemic in Nigeria because it's not just sporadic. So it's a yearly outbreak that occurs during the dry season between December and April. So always have a high index of suspicion when managing patients with unexplained fever. Use of face masks, hand gloves, sanitizers, and frequent hand washing should be will not be abandoned, and then continuous community health education is key to control this condition. Thank you very much for listening.
Thank you very much, Dr. Kuti. It's a very good one. I believe we are better with this information. Thank you. It's a very good one. Dr. Tanimu, please go ahead.
Okay, thank you very much for this very good presentation. It's a nice one. And in addition, you have to, as the first thing, you isolate any PCR positive patient with Lassa fever, any diagnosed patient you isolate. You after isolation, barrier nursing, a key for protection of the workers and also for the workers. The second thing is that the three regimens are mainly McCormick, modified McCormick, and the ARUA regiment. The issue with modified McCormick is not only for pregnant women. Any patient that have severe form of Lassa fever is also an indication for use of modified McCormick. And the caveat for the main difference between McCormick and modified McCormick is the loading dose differs. In McCormick, is 33 milligram per kilogram body weight in 300 mils of normal or dextrosaline over 30 minutes start. Then 16 milligram per kilogram body weight in 300 mils of normal saline or dextrosaline over 30 minutes at day 1 to 4 at 6 hourly. Then 8 milligram per kilogram body weight in 300 mils of normal saline or dextrosaline over 30 minutes 8 hourly in day 5 to 10. The difference with modified McCormick is in modified McCormick, the start loading dose is 100 milligram per kilogram body weight. But you have to divide them you have to divide the loading dose to start in the as a start dose. You have to divide the loading dose in modified McCormick. The total loading dose is 100 milligrams, but you have to give 2/3 first in 300 mils of normal saline or dextrosaline over 30 minutes. Then after 8 hours of the 2/3 of the loading dose, then you give the 1/3 remaining dose, the same procedure in 300 mils of normal or dextrosaline over 30 minutes. And then that is the loading dose for the modified McCormick. Then you continue as then the remaining 1/3 is given 8 hours later in normal saline or dextrosaline. Then you continue like McCormick. It's just the loading dose, but you continue as McCormick, previous McCormick at 10 milligram per kilogram body weight in 300 mils of normal or dextrosaline over 30 minutes, 6 hourly at day 2 to 5. Then 8 milligram per kilogram body weight in 300 mils of normal or dextrosaline over 30 minutes at day 6 to 10. As the main difference between ARUA regimen and modified McCormick is the continuation phase. The ARUA regimen continuation phase they have the ARUA regimen loading dose is the same thing as modified McCormick. The same procedure with the use of normal saline and the same duration of delivery. But the issue is the modified and the ARUA regimen. You continue at day 2 as 225 milligram per kilogram in 300 mils of normal saline daily for at day 2 to 4, then 12.5 milligram per kilogram body weight 300 mils of normal saline at day 5 to 10. So that is the main difference. But most of the time, people are more in support of the ARUA regimen because it it is just like modified McCormick in some with similar elements, and also more to do. It can also be used in pregnant and also severely ill patient, irrespective of the. So, but by and large, it's a very good presentation at the time it is needed. I also stand to be corrected always. Thank you very much.
Thank you, Dr. Tanimu, for this contribution. We will still entertain some few more contributions. However, we don't have much time. Dr. Dalhatu is raising his hand. Please, let's be very short. And meanwhile, the next presenter should start preparing to project his slide. Thank you.
Thank you, class rep, for the presentation. Thank you, Dr. Ha. It's a nice presentation. In addition to what Dr. Tanimu mentioned, we usually prefer to use IROA regimen because it limits contact with the patient as a source of infection control in the hospital setting. You remember in IROA regimen, it's usually daily dosing, therefore you limit contact with the patient. However, if you looked at it, the dosage, the concentration of drug used in IROA regimen is more, and sometimes patient may tend to react more with IROA regimen than when you compare it with the McCormick regimen. But usually we prefer using IROA regimen due to the limit contact with the patient. Addition to what mentioned, the issue of contact tracing is usually advised to, as much as possible, as especially the index case, if we can do contact tracing and we identify his movements and all the initial contact he have, we tend to limit the spread of the infection in the community. In most cases, if the initial contact are identified, screened, and treated, usually the epidemic or the epidemics tend to be curtailed. Then I saw somewhere human-to-human transmission. Usually there is no inhalation. Inhalation mode is not that identified. The inhalational transmission is usually between rodents and human, but for human to human is mostly direct contact with the body fluids. By and large, it's a nice presentation. Thank you very much.
Thank you, Dr. Dalhat, for this wonderful contribution. I think if we have one more, we can entertain. However, before that, I'll read out the chart on the box. Dr. Esther Edwards said, thank you for the presentation. Please, what are the advantages of one regimen over the other? Kindly explain PCR identify virus within 7 to 10 days. All other ones were thanking you for this wonderful presentation. Thank you.
Okay, you said, what was the question again?
She said, thank you for the presentation. Please, what are the advantages of one regimen, meaning that over the other, which Dr. Elhat have explained already?
I think Dr. Bahatu just explained, you have lesser because of the dosing. Yes.
But she also wants to know why PCR to identify the virus should be done within 7 to 10 days.
No, I didn't say within 7 to 10 days. I say it can pick the virus within 7 to 10 days. So when patient presents, you can at any point, you can always test for the virus, because you have to confirm in the Lassa fever. So it's not like you have to wait after 7 days before you subject your patient to testing for Lassa fever.
Thank you very much, Chief. Meanwhile, Dr. Jamila, Success, Edadi, and I were thanking you for this amazing presentation. I think Dr. Success should start trying to present her slide.
Let me share. Yeah, let me share my. Sorry. Okay, you can go ahead. Success.
morning, all. I don't know if my screen is seen.
Yes, Chief.
Right.
Thank you.
Go ahead, man.
Okay. Good morning. I'm Dr. Bamba, success presenting management of poisoning. This is my outline. As a way for introduction, poisoning is a clinical condition produced by exposure to an agent that is considered to be toxic. Okay, so it could be in form of swallowing, inhalation, injection, even in form of toxins and of gases. It's important for us to know that the effects of poisons are different, as various classes of toxins produce different toxic effects. Poisons can be toxic, can be local or systemic. And the reasons why, of course, poison occur could be due to recreational drugs or in alcohol intoxication, occupational exposure, deliberate self-harm, accidental ingestion, chemical exposures, or maybe these patients have underlying psychiatric conditions. Now, WHO has said that both patients that have acute unintentional poisonings and in those that have intentional poisoning, it's met about 2 million per year. This is one of the ways of classifying toxins. Briefly, one of the highlights of this lecture will be talking about toxin syndromes. Now, these are actually signs and symptoms associated with different classes of toxins, and usually based on autonomic effect of the toxin, meaning that different toxins can come with different clinical parameters, such as vital signs, of course, the pupils, the eye examination findings, the skin and secretion. What does that mean? So if a patient has cholinergic intoxication, we expect that this patient will have more of copious, cholinergic intoxication is seen in things like organophosphate poisoning. So we expect that this person will have things like myotic pupils. These patients will have copious secretions, unlike patients that have anticholinergic intoxications that we expect dry mouth, dry skin, reduce them, or loss of innervation, of the cholinergic neurons. So these are some of the toxicology screens. So like I said, patients that have cholinergic toxicity, example, patients with organophosphate poisoning, we remember the famous mnemonics, dumbbell. So these patients have more secretions, however, they have bradycardia and meiosis. Unlike patients, it's also important for us to know that both in patients with cholinergic and opioid toxicity, they come down with meiosis. However, patients with opioid toxicity, we have the classic triad of altered consciousness, respiratory depression, and of course, meiosis. Then these are the antidotes for organophosphate poisoning. We give atropine, and of course, for acetaminophen, we give N-acetylcysteine, amongst others. Now, these are other toxicology syndromes, acetaminophen poisoning, venom, lead, botulinum, and amongst others. Now, it's important for paracetamol is one of the most commonly used analgesic, and is mainly metabolized in the liver to non-toxic conjugates, which are then excreted. However, when there's acetaminophen toxicity, these toxic conjugates become saturated. Hence, the excessive paracetamol is then oxidized by the CYP enzymes to toxic reactive metabolite like the NAPQ1. And this is what actually causes the fulminant liver failure and other damages to the liver. It can also have affect extra hepatic organs. Now, for managing paracetamol, apart from the multidisciplinary approach and the supportive care, I've talked of the specific antidote N-acetylcysteine, which is usually more effective, is given within 8 hours of injection. Now, for patients with lead poisoning, what are their sources? So you have a patient that has history of staying in maybe old houses with lead paints, plumbing materials that contain lead, and of course, operation exposures. Usually they come down with abdominal pain, which is known as lead colic, and then other clinical features are seen. Worthy of note is investigations we do for them, the complete blood counts, where what is seen is basophilic stapling of the red blood cells and microcytic hypochromic anemia. Now, how do we manage patients with lead poisoning? As much as possible, we should remove them from the source of lead and then chelation therapy with Susima. Then for arsenic poisoning, this is one of the very toxic gases too, or compounds. You usually have this characteristic garlic smell in breath. And so these patients can come down with GI symptoms, hematological symptoms, neurological symptoms, and of course, they can have cardiac and respiratory instability. When you do an abdominal radiograph, you're going to see a GI radiopaque material. And then for treating these patients, activated charcoal is important. And then, of course, chelation therapy with either dimercaprol or Susima. For patients with cyanide poisoning, apart from the domestic sources and industrial causes, they can also have dietary causes. So, for example, the seeds of plum, apple, pear, bitter almond could be sources of cyanide poisoning. And cyanide is a rapidly lethal mitochondrial toxin that can cause death within minutes to hours of exposure. These patients classically have this cherry red skin coloration. And so both cardiovascular, respiratory, and GI symptoms can be seen. In investigations, elevated blood cyanide levels will be seen. Of course, treatment is supportive. Activated charcoal can be given. And of course, the antidote, sodium thiosulfate or sodium nitrate can be given. For carbon monoxide poisoning, usually the sources are from camping gas, polyfunctioning heated material from generators, and motor vehicles. Carbon monoxide is an odorless, tasteless, and colorless gas. Patients may also have cherry red flush skin discoloration, including neurological and cardiovascular instability. Treatment is with high flow, 100% oxygen. For mercury poisoning, of course, the sources include occupational sources, and these patients too can also have more of neuropsychiatric symptoms. And treatment too is cessation of exposure and then chelation treatment. For botulism, this can be gotten from food sources, from home canning, and of course from colonization of wound infection. It could be life-threatening and has many other types, including forms, including the inhalational botulism, which is the aerosolized toxin that has been used for bioterrorism in wars and also in wars. Then it's important for us to know too that even the botulism is quite harmful. There are effects that are of therapeutic importance for us, such as in the treatment of conditions such as dystonias, chronic migraine, strabismus. So it also has some therapeutic advantages. Now, these patients may come down, with abdominal symptoms if it's from the foodborne botulism, respiratory paralysis, also reduce them, and like cremation, and of course, orthostatic hypotension. Now, for managing patients with botulism, multidisciplinary approach is important. Antitoxin also important, and then the use of antibiotics such as metronidazole. How do we make a diagnosis of toxic syndrome? So a focused poisoning survey is important. A careful history, very crucial, a detailed clinical examination, and then essential clinical laboratory tests, including toxicology screening. So this history should actually involve the type of toxin amount, the route of exposure, the reason, and of course, if there's history of psychiatric illnesses, amongst others. For the clinical approach, this is usually multidisciplinary. And of course, we need to resuscitate this patient. Supportive care is too important. Laboratory and assessment also important, so that we can also diagnose the type of poison. Of course, because even our toxic syndromes too will also help us to clinch the differentials. Now, the contamination too is another very important principle of management. The combination of the GI, the skin, and also the eyes also enhance elimination of the toxins, administration of the antidote, and then prevention of re-exposure. For the supportive care, of course, we want to protect the airways, we want to give the hemodynamic support, we want to monitor vital signs and make sure that we correct electrolyte imbalances and also temperature abnormalities, including making sure that our patient is not hypoglycemic. And of course, does not have any abnormalities, with the blood glucose level. So for the contamination, for the eyes, we tell the patient to wash off the eyes every, like for 15 to 20 minutes, and it may be repeated. Patients should avoid rubbing the eyes for the skin, the clothes of the patient should be removed, and this patient should be washed, should bathe, have this continuous bath until, the particles have been washed off. And then it's important for us to also look at the nails of the patient, whether these toxins are hidden on the nails or hair behind the ears. And so for gastric, so this is not the compensation, this is gastric, and of course, emesis. Now we could also give activated charcoal. We could do whole boil irrigation, and then gastric. It's important for us to know that this gastric emptying is usually preferred within 60 minutes of course, of the indigestion of the toxin. For the activated charcoal, it's usually given with a cathetic, and the dose is 1 gram per kg. There are some toxins, okay, that we could use activated charcoal for, and they include medication, some drug toxicity like theophylline, digoxin, carbamazepine, salicylates, and so on. While for those that are not bound to activated charcoal, they include heavy metals, hydrocarbon, lithium, and of course other small ions. Now, for the enhanced elimination of these toxins, we could use the following processes: alkalinization, although this is no longer used because of the risk of rhabdomyolysis; chelation, like I've said in those other I've mentioned previously, Susima, that we use in lead poisoning and mercury poisoning. Of course, we want to also do multi-dose activated charcoal, especially when this dose is when the toxin is actually large. And of course, others include hemoperfusion, hyperbaric oxygen, and then hemodialysis, when all these medical conservative management are failed. This is a monogram showing the emergency evaluation and management of poisons. And of course, this is just a summary of what I've said concerning the principles of management of poisons. I want to say that it's important that we stress on prevention. So adults, as much as possible with unintentional exposure, should be instructed on safe use of medications. And if they are confused patients, they need assistance. Errors too in dosing by health workers is also a major part of what contributes to toxicity. And so education efforts should be done. Patients should avoid, should be advised to avoid circumstances. Circumstances that result in, so prevention, avoid circumstances that result in chemical exposure or poisoning. Then for children too, it's important that these poisons are out of their limits so they cannot access it. Then for patients that have psychiatric conditions, they should go for psychiatric evaluation and follow-ups too. I want to conclude by saying that every poison is different from others, and poisoning can be accidental, can be deliberate, non-accidental, misadventurous, and homicidal. History taking, excuse me, especially using the knowledge of toxic syndromes, helps narrow the differential as well as toxicology screening. And this will help to identify the type of toxin, which is very essential in our management. The contaminating the patient, especially external decontamination, to protect yourself and then the patient from further exposures, providing aggressive supportive care and using antidotes when available improves outcome. Psychiatric care is also key to management, as a significant proportion of overdose cases comprise of suicidal attempts. Thanks for listening.
Thank you, Dr. Success, for a wonderful presentation and lucid presentation. Thank you very much. So we invite comments, contribution. Okay, Dr. Tanimu say good presentation. Thank you very much. Dr. Momodu say thank you for the presentation. What dose of paracetamol is likely to cause acute hepatic failure? What are the indications for N-acetylcysteine in paracetamol poisoning? Note that blood samplings are taken after 4 hours. Ingestion in a staggered overdose, you should assay the paracetamol level, INR, and LFTs. Do not treat the paracetamol if below 10 and INR 1.3 or less, and ALT is normal. Okay, so he's asking at what dose of paracetamol you have acute hepatic failure. What are the indications for N-acetyl?
Okay, so okay.
Yeah. And then the other ones, I'm coming. And then the other ones are just applauding your presentation. Yeah, applauding your presentation. Okay, I think that is, so you can go ahead.
Okay, thank you so much, Dr. Atta. Okay, so thanks for comments on contributions and questions. So for mild toxicity in paracetamol, I've seen in the slide, so maybe patient takes like 10 and sometimes up to 15 tablets. And, you watch for 14 hours before you now check the toxicity. So it's not, you don't want to give, the antidote, that's the N-acetylcysteine. However, in severe liver toxicity, where this patient takes more than 30 tablets, and of course, the patients with all these, the parameters, the liver function test, this deranged and so on, and of course, the clinical symptoms of the patient, you want to give an antidote. Okay, so it's not for all cases of acetaminophen toxicity, we give the antidote, especially if it's just a mild toxicity. And the truth is that many of the patients, if you want to follow the natural history, okay, so initially many of the patients are asymptomatic. However, patients with mild toxicity may not really come down with so much, symptoms compared to those with severe liver toxicity. So depending on the number of tablets, the liver, if it's severe or mild toxicity, that's when we give the antidote. Thank you.
Okay, thank you. Thank you for any other contribution. Okay, is there another contribution, or we'll go to the next? We still have time. So we can go to the next. Who's ready for his or her presentation? Can share us. Can you indicate so that we know you, so that we can share your slide? Dr. Tanimo, are you ready for us?
Sir, I have no presentation.
No, you have.
Okay.
Leishmaniasis. You're supposed to present leishmaniasis.
Okay. I'm sorry. Wallah, I don't know.
Okay, we dropped it in the...
Dr. Kalim will understand. Any other person, like what I told some persons, because of how we're trying to quickly round up, you mustn't have a slide. It can just be a normal discussion. We understand you guys are traveling soon, so there's a lot going on. So your slide is ready, your slide is not ready, just present so we can answer as much as you can. The specialists are in the house, so it's a contribution, so everybody will contribute and we all learn, and that is it. So there must not be a slide. So Dr. Tanimu, if you can say if you can present Leishmaniasis, fine. If you cannot, let the next presenter, you can do that. You can present tomorrow, because from the look of things, we might end this discussion tomorrow. So please, any other person that is ready, slide is available, slide is not available, please present. We understand.
I saw Dr. Dalahatu's hand up.
Good morning.
Yes,
Yes.
I was not part of the people that are giving presentation, but if the person for leprosy...
Hello, Dr. Daratu, we can't hear you.
Sorry, can you hear me now?
Yes, we can hear you.
Okay, I said I wasn't part of the people that are supposed to present, but if the person presenting leprosy is not ready, I can say something on leprosy if the house permits.
Okay, just go ahead. Just go ahead, we'll contribute.
Okay.
Yeah, Dr. Esther, you're supposed to present leprosy, so you can do
Dr.
joint.
Esther can present leprosy any day, anytime. She's a dermatologist, so she can start. Then Dr. Dahatu, she's going for this exam and she's ready. She's
Yes, I
breathing
think
leprosy every. She's
yes, I think she
ready. So
had
don't
some.
take that from her. I know her. She's
No,
very
Good
ready.
morning, ma. Yes, I'm ready. I traveled yesterday, so I'll present
you see
tomorrow. I
what
don't
I
have
mean.
light.
She's
I'll present
ready. She's a
tomorrow.
dermatologist. She's ready. We breathe leprosy. So let her start. Then let her start. Then Dr. Dahatu will come in. Or we don't want to. It's a discussion. We don't want to give gaps since we don't have so much time. You see, Dr. Esther has traveled already. That's what I was just trying to confirm, that people are traveling, so we have to quickly round this session up. Dr. Esther, you can start. Dr. Dahatu will give you support. Thank you so much.
You can share your slide later on for us.
Okay, good morning, our teachers. Good morning, colleagues. Okay, it's just a minute. Let me get some things I wrote down. Okay, so I'll briefly discuss leprosy. Okay, so by way of introduction, leprosy is one of the neglected tropical diseases, and it's a chronic granulomatous disease that primarily affects the skin and the peripheral nerves. And we also know that it was initially known as leprosy and then later changed to Hansen's disease in honor of the doctor that discovered the disease, had Hansen's in 1873. So it was a disease that was attached to stigma and then isolation. In the past, it was actually priests that treat this infection, and people are even asked to live outside their environment and they are termed unclean and have to ring bells when they come out in the environment. So the stigma is actually very, very, very high. Epidemiology, I'll just keep that. And then, so the causative organism is Mycobacterium leprae, and it's an obligate intracellular gram-positive and non-cultivable acid-fast bacilli that reproduces around 27 to 30 degrees, and is said to grow better in cooler areas of the body, which commonly is the earlobe, where you have dense accumulation of these mycobacteria. The risk factors include people that live in endemic areas, people that live in close proximity and are poor, and then contact with the 9-banded armadillos. It has also been found to be transmitted via tattooing, so by direct dermal inoculation. There are some genetic components that are said to be at higher risk of acquiring this infection. So people that have the VDR genes, which is seen mainly in Indians, and then the PAC2 gene, which is seen in people in Brazil. So the classification. So basically there are 3 classes of classification. We have the pathological classification, where it's classified into tuberculoid and lepromatous, and then the Ridley-Joblin system, where it's classified into tuberculoid, starting from the pole that has immunity, which is the tuberculoid pole, down to the lepromatous pole, and then the borderline in between. The WHO classification classified them based on number of bacilli and also the number of lesions. So because of the limitation in doing the slit smear, it's now been limited to number of lesions. So possibly bacilli, when the lesions are 2 to 5, and then multibacillary when it's greater than 5 lesions. Briefly, pathophysiology, this organism has affinity for the Schwann cells, and that's because of what the bacteria possess, which is the phenolic glycolipid 1 lipoprotein. So they have affinity for the Schwann cells, they bind to them and then cause a downregulation of the inflammatory immune system. And then subsequently, there is Schwann cell demyelination and axonal damage. This essentially results in the symptoms that we see. So in looking at the classifications, so we have, I'll start with intermediate leprosy. Intermediate leprosy, it's like a class on its own. Here, the patients have a single lesion. Usually it's seen in children and they are said to have good immunity. So most times the lesion will resolve on its own. But in about 25% of these patients, they may progress to the other spectrum. However, it is self-limiting. When we do the histology for the intermediate leprosy, what is seen usually, we have superficial and deep lymphocytic infiltrates around the adnexal structures. So periadnexal lymphocytic infiltrates are seen both around the perineum, around the hair follicle. So that's what is marked about it. Usually they are solitary and then the sensation may be normal. Most times it's normal. That's how you differentiate it with the tuberculoid. So for the tuberculoid lesions, they are usually few, most times 1 or less than 3. And here the lesions are well demarcated, hypopigmented lesions, and then they are asymmetric and hypoaesthetic, as against the intermediate where sensation is normal, is hypoaesthetic, and then the skin is shiny and hairless. So when we do the histology, what is seen usually is a non-casseating epithelioid granulomas that are seen mainly in the extending to the papillary dermis. And then we also see lymphocytic infiltrate, perineural, perivascular, lymphocytic infiltrates. Then there is no green zone. So as we'll see when I talk about lepromatous leprosy, there's what is called the green zone, which is the unaffected area. So here there is no green zone. The inflammatory infiltrates extend into the subepidermal layer. So then for the borderline here, as against tuberculoid, the lesions are multiple. They are more than the ones are seen in the tuberculoid leprosy. And because of that, there are numerous lesions which have ill-defined margins. They are also hypopigmented. The histology here, usually they have poorly defined epithelioid granulomas, and then there is also presence of green zone. So the borderline and lepromatous have what is called the green zone. Okay. So for the lepromatous leprosy, here the patient's immune system is more depressed. There is low cell immunity. So there are numerous of these bacilli, and because of that, they have predominant widespread lesions, and they're usually symmetrical. So when we do the histology, what is seen is diffuse infiltrates of foam cells or viscous cells. So these are macrophages that have engulfed the bacilli in them. So that's what is seen. And then here we now have the presence of the green zone, which is the uninvolved subepidermal area. So it's free of inflammatory cells. There is no reaction at that point. We also have a component known as histoid leprosy. So this is a variant of lepromatous leprosy, and the patients present with fibrotic papules. Sometimes they appear nodular. And with the histology here, what is seen pathognomic for it is the spindle cells. If you remember when we talked about KS, I was saying there are other conditions you see spindle cells. So this is one of them. So in histoid leprosy, what is seen is spindle cells. So as part of the problems associated with leprosy is affectation of the peripheral nerves. So they can present with enlarged nerves, and usually commonly the greater auricular nerve is the most involved. Okay, briefly to talk about the lepra reactions. So we have lepra reactions, and these are sudden inflammatory reactions that occur due to circulating immune complex. They are grouped into 3 classes. We have the type 1 lepra reaction, type 2, and the Lucio phenomenon. The precipitating factors is either the patient has been effectively treated or commenced treatment, or any form of physical stress. Even pregnancy and lactation can also be a risk factor. So the type 1 lepra reaction is also grouped into reversal or downgrading. So reversal is when it reverses back to the tuberculoid pool, or downgrading when it's progressing to the lepromatous pool. What happens here is most commonly seen in people that have borderline tuberculosis, tuberculoid, and borderline. So it's said to be a sudden reaction which occurs usually in the first year of treatment. Some people will say it can occur at any time, but mainly it occurs in the first year of treatment. After you commence your therapy, these patients begin to have inflammatory reactions of the old lesions and also new lesions. So the old lesions become edematous and then swollen, and then the new lesions can also appear at the same time. It's said to be a type 4 hypersensitivity response, and then there are no systemic symptoms. That's what differentiates it with type 2 lepra reaction. Essentially, the treatment is use of oral prednisolone, can be given at 0.5 to 1 milligram per kg. Other drugs that can be used include analgesia for pain relief, and then we can also use cyclosporine. Type 2 lepra reaction is also known as erythema nodosum leprosum, and this one, as against type 1, is seen in borderline lepromatous. Type 1, I said, is seen in borderline tuberculoid, and then here is borderline lepromatous, or the lepromatous variants. So here they have sudden eruption of subcutaneous nodules, and it's seen within the 2nd year of treatment. And then another difference is here there are systemic symptoms. So these patients can present with fever, weight loss, anorexia, and lymphadenopathy. They also have renal involvement and then even liver failure. So as against type 1, here we have type 3 hypersensitivity response. And then the treatments that can be used is the use of thalidomide, and then systemic steroids can also be used. So for the Lucio phenomenon, here basically it's seen it can be seen in lepromatous leprosy, and then the risk is higher in Mexican population, people of Mexican ethnicity. So what they have classically is a form of small vessel vasculitis, and they present with necrotizing vasculitic lesions on histology. So investigations that can be done for making a diagnosis, we have the slit skin and smear, which is done mainly from the earlobe, and then we use it to check for the load of the microbacteria. Then we can also use nasal smear. We can culture this organism is very difficult to culture, like I mentioned earlier. So culture is not sensitive. Other things that can be done include a PCR, and then if we do a tissue biopsy and histology, it will also tell us the variants, whether it's lepromatous or tuberculoid or any of the subtypes, or even the lepra reactions. A lepromine skin test can also be done, and this is done by injection of intradermal injection of lepromine 0.1 ml. It's just like what we do for the Mantle test. However, this is read within 48 hours. If there is erythema, this is the early reaction. It's known as the Fernandez reaction, or when the result is read after 3 to 4 weeks, by the appearance of a purple or nodule, that is known as the Mitsuda reaction. Other investigations that can be done include serological assay of the this mycobacterial cell wall, which is the phenolic glycoprotein lipid 1. It's also said to be specific and sensitive. We can also use the lymphocyte migration inhibition test for making diagnosis. So the treatment options, we have medical and surgical therapy. The medical therapy is aimed at halting and then halting this disease and limiting the complications. So we have, they are classified based on whether paucibacillary or multibacillary. So for both pauci and multibacillary, the current WHO recommendation is to use the 3 drugs, which is rifampicin, clofazimine, and dapsone. We have the daily dosing and then the monthly dosing. For paucibacillary is shortened to 6 months, while for multibacillary is for 1 year. That's what is recommended. Then for single lesions, we can give rifampicin, ofloxacin, and minocycline. Surgical therapy is mainly aimed at repairing the deformities that these patients have. So like I said, the current WHO recommendation is that we use the 3 drugs for both pauci and multibacillary. However, currently, as at December, I've not checked this year, the National Leprosy Center is still using the old guideline where the paucibacillary leprosy is treated with only 2 drugs, rifampicin and dapsone. Just for us to take note. So complications can be psychological or pharmacological or medical. Psychological, they have stigma, social withdrawal, low self-esteem. And then for the medical, they have auto-amputation, neuropathic ulcers, they can have osteomyelitis, and so many others. So the differential diagnosis will include other dermatophyte infections that present with hypopigmented lesions. How to differentiate it is sensation in the dermatophyte infections are intact, and then there's scaling in dermatophyte infections. Other differentials will include things like vitiligo. So in vitiligo, we have what is called loss of textural change. So when you roll over the lesions, you will not feel any difference with the normal skin. However, in tuberculoid leprosy, which is commonly a close differential, there is textural change and then loss of sensation. Other things like idiopathic goiter hypomelanosis. These patients present with like eruptions of hypopigmented lesions, multiple overextensor surfaces. So sensation in this area is also intact. So prevention, people have talked about BCG having some form of conferred immunity in about 60% of individuals. Sorry, I forgot to mention the incubation period. So usually it's prolonged incubation. People have talked about about 1 year to 40 years with an average of 5 to 10 years. And then as part of the risk factors, even though I talked about close contact and relational droplets, is actually sustained contact. So it's not something you just body balls or stay close to someone in your day, and then you eventually contract this disease. So I'll stop here for others to contribute. Thank you.
Nonsense. So, Esther. And just briefly, of time as well. Sorry, Dalatu.
Okay. Thank you, Dr. Esther, for the wonderful presentation. She has said most of the thing and most of the thing are in line. In addition to what she mentioned, there is a diagnostic criteria for the leprosy, which are 3: the anesthetic hypopigmented skin lesion, then the nerves enlargement, and positive slit skin smear. So having 2 out of the 3, we make a clinical diagnosis of leprosy. And then the classification, she mentioned them. The WHO is the one used for the treatment to categorize patients whether to have a particular duration of treatment. And then the treatment for paucibacillary leprosy ranges between 6 to 9 months. It's still within the duration, meaning patient has a period that he can interrupt his treatment up to 9 months is allowed. While for the multibacillary leprosy, the treatment duration is between 1 year and up to 18 months. So meaning also patient could have a period that the allowable interruption period. But if a patient interrupted for more than 12 months, for more than 9 months, in paucibacillary leprosy, we have to start the treatment afresh. And for multibacillary leprosy, if they are interrupted for more than 18 months, also the treatment has to start afresh. And then the issue of lepra reaction. Lepra reaction can come before the diagnosis, while patient on treatment, or even after the treatment. Especially for the type 2 lepra reaction categorizes into two. We have the mild and the severe one. The severe form of reaction is when it occurs around the eyes or around the face, or when it's involved major nerve trunks, or when it's involved around the joints. The most important thing the WHO is looking at for the leprosy is the issue of the lepra reaction, because it's the one that usually causes disability. If we look at the literature and the pathogenesis and the everything about leprosy, usually it's not a disease that kills, but usually patients tend to come down with a number of disability. So the most important factor that predisposes patient to disability is lepra reaction, because it's the one that inflammation around the nerve. And once there is inflammation, if less than 6 months, you may be able to salvage the nerve, but for when it is prolonged, you may not be able to salvage the nerve, and all the other complications can come in. Anesthetics lesion predisposes to decreased blood supply to the area, subsequent ulceration, and then multiple infection, and at the end of the day, they lost the limb or amputation, either therapeutic amputation or auto amputation. And some of them, they may have overwhelming sepsis from there, and eventually they succumb. So this is my few comments. Thank you very much for the presentation.
Tata, your voice is not clear. It's your network.
Yeah, network.
More food. Hello? It's more food.
Hello, can you hear me?
Yes, it's better.
Dr. Tanimu, you can make your comments since Dr. Atta is having network challenges.
Okay, thank you. Thank you very much for the presenter and for my Oga, Dr. Alhatu. You have done very good jobs. In addition, for the treatment, medications are some that patient will be observed to take the drug. That means there is the other drugs patient should be self-administered, and the one that is what? That is observed. So the monthly medication are the ones that patient visit the clinic and he is observed by the health personnel to have swallowed the drug. That is observed. And there are those that patient will take at home himself. That is the self-administered. So among the drugs that are to be observed are the monthly medications. Rifampicin 600 milligram monthly should be taken by the patient during the clinic visit. That means he takes them under the watching of the clinical or medical staff. While also clofazimine, the clofazimine are divided. There is one that he can take that is self-administered daily, and there's one the dose that also he will go into the clinic in the monthly period to take. That is what? That is observed. So the one that is, he takes 300 milligram monthly in the clinic as what? Observed. And he takes the clofazimine 300 milligram monthly as observed. And he takes also 50 milligram daily, self-administered. And so this Dapsone is self-administered 100 milligram daily. So at least he need to have monthly clinic visits. In the monthly clinic visit, he takes a clofazimine 300 milligram under observation by the clinical staff, and also rifampicin monthly. So patient with leprosy should take monthly clinic visit at least to be administered 600 milligram rifampicin and 300 milligram monthly of the clofazimine. But the ones that are self-administered at home are still the clofazimine, but 50 milligram daily, and also Dapsone 100 milligram daily. This regimen is the same. The regimen is the same between multibacillary leprosy and paucibacillary leprosy. Is just the duration that is different. The duration for multibacillary leprosy treatment is 12 months, while the duration for paucibacillary is 6 months. And there are issues with the Lepera reaction, like type 1. In the treatment, the surgical treatment, and also beside prednisolone in type 1 Lepera reaction, patients should undergo physiotherapy because they can have sudden loss of function of involving a section of nerve. So they can have physiotherapy. They can also have rest. They can also be splitting, and also sometimes surgical nerve decompression. And the issue of the type 2 is that patients are also given, in addition to prednisolone and thalidomide, patients are also placed on high-dose clofazimine. So other differential of leprosy depend on the presentation. It is paucibacillary, mostly tubercular leprosy. The differential include vitiligo, cutaneous leishmaniasis, vitiligo, cutaneous leishmaniasis, and also cutaneous tuberculosis. While if patient is having features of lepromatous leprosy, the differential are different. The differential for lepromatous leprosy include neurofibromatosis, noma, noma, and other forms of differential. Even sometimes even the cutaneous advanced and also So that is it. There are some of the definitive diagnosis mainly rests on the nerve histology, but it's not much needed. But they said full thickness, dermal and epidermal stent with H and E and pitch paraco or ZN demonstrate AFB more sensitive with lepromatous leprosy. But there is nerve biopsy to rule out. Nerve biopsy is done if the presentation is ambiguous, so that you rule out hereditary neuropathies or polyarthritis nodosa in some cases. Purely sensory nerve, a sample from purely sensory nerve is taken like sural nerve or radial cutaneous nerve used to confirm diagnosis, but rarely necessary in the presentation. Rarely necessary. So histology include dermatitis, giant cell infiltration of nerve bundle with mononuclear cell and granulomas, numerous AFB with part-laden macrophages, lepromatous leprosy, and paucity of lymphocytes, few to no AFB in tubercular leprosy. So, but by and large, it's a very good presentation. It's a very good presentation, and they have done very well. Dr. Latu and the other one, I support you. You are very good. Thank you very much.
Thank you. Yeah. Thank you, Dr. Tanimu, for an extensive contribution. So I'll just read some few comments in the chat box and then we'll close the class. Our time is fast spent. So Dr. Momodu say, thank you so much for the presentation. How do we differentiate between relapse and reaction in leprosy management? Dr. Fee is saying that the duration of allowable treatment interruption is not clear. I think Dr. Dalhatu took that, so Dr. Dalhatu just take note in case in just a single sentence can just help us out there. The duration of allowable treatment duration. And I think those are the two questions. How do you differentiate between relapse and reaction in leprosy? And then the duration of allowable treatment duration.
Okay,
Hello,
thank you, sir.
Yeah.
Doctor,
Yes.
are we okay? You can continue.
Yes,
Your network seems
Dr.
better
Dalatu.
now.
Yes, Dr. Dalatu, you can.
Okay,
go
the
ahead.
allowable duration is for post-bacillary leprosy duration 6 months to 9 months. For multibacillary leprosy, 12 months to 18 months. The relapse is not that very common, but usually what patients tend to have is actually leper reaction. Remember, the immune system can kill the bacilli, but the immune system doesn't have a mechanism to get rid of the proteins component and the dead bacilli. So sometimes you may do skin smear and you may see positive result. But if you evaluate the patient very well, usually you find out they are having leper reaction. Like we mentioned, they can have leper reaction even long after the treatment. But there are some cases of relapse and they have a different treatment modality. I can't remember exactly what is being used, but is still clofazimine is central in the relapse treatment. Thank you.
All right, thank you, Dr. Dalhatu. So we'll hand over to our teachers, Dr. Christabel.
Dr.
Yes.
Thank you. I must appreciate Dr. Dalhatu. Thank you so much for your contribution. I love the attitude of let me discuss, some people will just hide themselves there. I really appreciate that. Thank you so much. I must also appreciate the speakers today, Dr. Atta, Dr. Success, and Dr. Esther. I know this is the last time I'm hearing you guys as residents. Subsequently, you'll be presenting as fellows. So congratulations once again. And you guys spoke like fellows, so much authority, was so clear, was so lucid. So congratulations, that's all I have to say really. Thank you so much. It shows you are there already. So congratulations once again. We appreciate you all. The all anchors of today, Dr. Yahaya, Dr. Atta. Thank you so much for anchoring the meetings. And people that contributed, Dr. Tanimu, as usual, thank you so much. Once again, congratulations, Dr. Tanimu. I know you picked it already. Dr. Tahatu, thank you. I don't know if I missed any other person that contributed. Everyone that contributed, thank you. We appreciate you all. We appreciate your consistency. And our teachers, and I started Jennifer. Jennifer, thank you for coming to class. Chief Koke, Chief Remigos, Chief Chitsu, and Chief Vance in absentia. Thank you so much. Thank you. We appreciate you all. We appreciate your sacrifices. Thank you so much. I think, as I said yesterday, so we might have to stop